Hello, this is Landmesser. I'm Deputy Editor of the European Heart Journal. We are here at the EHJ meeting in London, and it's a great pleasure and honor to have with me Professor Vivek Reddy from the Mount Sinai Hospital in New York City. And he just presented at this meeting one of the most interesting studies, the Leadless 2 trial, which is actually an interim analysis that was published in partly now in the New England Journal, which is also, I think, quite unusual that an interim analysis gets already accepted in the New England. And this just shows how much excitement there is in this new development of leadless pacemakers. Vivek, could you maybe give us a short insight into the design of the trial and how you, of course, will come then how you interpret the findings on efficacy and safety as far as now?
Sure. Thanks, first of all, for having me here at the European Heart Journal. So the Leadless 2 trial is a trial that looked at the leadless pacemaker. And by way of background, as you know, pacemakers have been devices that we've been using for half a century, and they're highly reliable devices, and I want to underscore that to begin with. Having said that, the pacemakers do have some issues. The pacemaker generator is placed in the shoulder, which can have, it's a surgical procedure which can have issues in terms of hematomas, infection, etc. And then probably the weakest link of the pacemaker system, the weakest link of the pacemaker system is the lead that goes from the pulse generator to the heart itself. As it travels in the vascular system. The lead can, as it bends and flexes over the lifetime of the patient and the lifetime of the lead, it can fracture, it can get infected, and removing these leads can be a difficult experience. And this is what prompted the development of the leadless pacemaker. So the idea is avoid some of these problems associated with the surgical procedure, avoid the problems that can be associated with the lead by encapsulating the whole pacemaker in a very small form factor. So this device is approximately 4 centimeters long, a little bit longer than 4 centimeters, 6 millimeters in diameter, and it's a cylindrical device. And the device is placed percutaneously. So it's advanced through the vascular system and from a femoral venous puncture, up the inferior vena cava, across through the right atrium, across the tricuspid valve, and placed entirely within the right ventricle. So this small device has all the components of a pacemaker, the battery, the electronics, as well as the pacing element itself. So the Leadless 2 trial was designed to try to understand how effective and how safe is this device in the hands of multiple operators. The study was a non-randomized study, which is an important point and is a potential and is an actual limitation of the trial. But it's a non-randomized study conducted in 3 countries, United States, Canada, and Australia, at 56 centers with 100 operators. And I want to start off by underscoring 100 operators, of which 99 had never performed a leadless pacemaker implantation. So unlike the millions of pacemakers experience that we have every year, this study captures the whole learning curve. There were no run-in patients, there were no leading patients. All the learning curve is captured within the trial, which is a strength of the trial itself. Since it's a non-randomized study, the trial was designed to have goals against historical controls of the use of standard pacemakers. So there was both an efficacy endpoint as well as a safety endpoint. The efficacy endpoint was looking at the first 300 patients enrolled in this trial, followed out to 6 months, and the ability for the pacemaker to sense and pace appropriately. The safety endpoint was again looking over the 6-month time period, but really the complications happened earlier around the time of implantation. It was looking at major safety events associated with the device and the implantation procedure. The primary analyses were both by intention to treat, though on the efficacy side there was an additional analysis of those patients who had successful implantation, what percent also had appropriate sensing and pacing. So those were the efficacy and safety criteria.
The design of the study, your goal were like 85% for the efficacy endpoint, and you reached 95%. Are you happy with that, or do you think that will still improve with more experience? And
no, I think so. The way that the performance goals were set up was that the lower confidence bound had to exceed that 85% or 86%, and it was achieved on both efficacy and safety. I think I'm happy that we were able to achieve the endpoints appropriately, but I think there are also improvements. You know, again, because this is early in our experience, we expect to see improvements on both the efficacy and the safety side, which I think is an important issue.
Mm-hmm. I think what's also impressive in the study, despite this were the first cases operating time was rather short. So on average in the range of 30 minutes, it might be with experience even get shorter. So it's a very fast procedure to implant these devices.
Yeah, it is. It's a fast procedure. Just simply from the operator perspective, it's also, how do I say it, a comfortable procedure, let's say. You're not standing at the shoulder with, you know, the fluoroscopy right next to you. You're standing about a foot away at the femoral venous site, which it makes it a little bit easier. I mean, not that that's the most important aspect of a procedure, but I think it is an advantage.
Let's come briefly to the safety aspect. You mentioned these safety endpoints, and overall, I think you reached your goal, and the rate of perforation was in the range of 1.5% and embolization 1.3. Do you think that's something that can further improve this experience, and how do you value this at the moment?
Yeah, no, I think that's a very important point. On the one hand, we did reach the safety endpoint. The major complication rate in the trial was about 6.5%, including all major complications. It's also important to note that all the complications that we saw occurred early, within the first couple of weeks. After 2 weeks, we didn't see any complications followed out. Now again, we only followed for 6 months on average, but at least at this sort of intermediate time, we didn't see complications. But the flip side is, it is important. These complications can be dangerous, and it's something that we hope will improve over time. If you look at the complications, the pericardial tamponade, so at the time of implantation, causing trauma that causes pericardial effusion and potential tamponade, this is the major complications that we get worried about. And we saw this in 1.3% of the 500 plus patients that we enrolled in the trial. And this includes both effusions that did not require intervention, as well as effusions that required either percutaneous or surgical intervention. It's an important complication. It's something that I expect will decrease over time. Just as a comparator, if you look at standard pacemaker implantation in large studies, large recent studies, the major pericardial tamponade rate is approximately 0.5%. Of course, with the standard pacemaker, you also have the pneumothorax complication, which is about 2%. So this is within the range, but of course we want this to be better with time.
I think that it's very important to keep in mind that with standard pacemaker, you have pneumothorax, as you mentioned, other complications as well that have to be considered. I think the other important question will be what will be the place of this device now? Which are the ideal patients? And of course, my understanding is it's also thought for a rather long-term implantation, not for like interval implantation. So how do you see the place of this device? What will be the ideal patients?
So let's talk about the battery life first. Because we followed 300 patients out to 6 months, we were able to estimate the battery life based on the device use characteristics. And actually what we saw was a mean battery life, or expect a mean battery life, of 15 years, which is pretty amazing. When you consider the mean age of this population was 76 years old, it's probably, it's likely that many of these patients will not even require a second pacemaker.
I mean, you mentioned the size of the device, and given that it's a big advance in technology of the battery size.
That's right. I mean, you wonder why we can't have this in our cell phones and other devices. Now, in terms of the role, I do want to underscore one important limitation of this device, which is it is a single chamber pacemaker device, single ventricular pacing. So, and if you look around the world, at all pacemakers that are implanted, depending on the country that you look at, it's somewhere between 15 to 30% of the pacemakers are single chamber pacemakers, which means the majority of patients who have dual chamber pacemakers would not be appropriate for this device, or this device would not be appropriate for them at this point. Having said that, looking forward, we fully expect, and I think we're going to see in the next couple of years, multi-chamber leadless pacing. That is, a leadless pacemaker that you can put not just in the bottom chamber, but a second one in the top chamber, or potentially even the left ventricle for left ventricular pacing. So what do you need? You need the ability to fix these in the various chambers, as well as communication between the devices, as well as enough battery life that this is all feasible. And this isn't science fiction. It's going to happen. The manufacturers of these devices are already working on this. So we expect in a couple years that we will have leadless pacing, not just for the single chamber pacing, but potentially for even multi-chamber pacing.
To implant such a device in the atrium is more challenging because, of course, the thinner wall may be a bit less forgiving compared to the ventricle.
Yeah, I think that's exactly the point. There'll be issues in terms of how do you affix to the thinner atrium. Perhaps you go to the Bachman's bundle region or the septal part of the atrium where it's thicker. Perhaps you use a different fixation mechanism. There are different strategies that one can consider, but that is certainly a challenge.
You clearly foresee a development towards also dual chamber, potentially even more development. But at the moment, obviously, of course, it's only appropriate for patients with ventricular. But within this population, do you think there is a particular population that will benefit most?
Yeah, that's a good question. I think, look, there are certain patients who are not good candidates for traditional pacing. For example, patients with diabetes or renal failure, these are patients that are higher risk for hematomas and sort of the surgical complications. And then there are certain unusual patients who have vascular issues, either SVC syndrome or problems with upper venous access. So that's a small population. I think what the Leadless 2 trial has shown, that albeit with some learning curve in terms of safety, that the device seems to be a good alternative to single-chamber pacemakers for the majority of patients. There are certainly other issues. As I said, there's some safety issues that the operators have to get past their learning curve. There's going to be some cost issues. As you can imagine, these are new devices. New devices are always more expensive than older devices, so that will be also another challenge. But ultimately, I fully expect that this is going to be used in a high percent of patients. I think patients will want it.
Clear. Well, thank you very much for this exciting also additional insights and your view also on the development of this technology. And thank you very much again for being with the European Heart Journal. We are very honored to have you here. Thank you very much.
It's a pleasure to be here. Thank you.